Coming to HLSA cardia, the first question that comes up is why would it be developing? Well, one of the important causes from the South American perspective can be Chagas disease. Most guys can answer that very easily. Chagas disease is transmitted by reduvate bug. The organism, as you are aware, is Trypanosoma cruzi. And this disease is more common in South America. So, can you think of a relatively more common cause than Chagas disease? The number one cause for HLSA cardia should be answered as autoimmunity. I have seen most guys casually answer idiopathic, which is not the case. Then it can be a paraneoplastic manifestation with the lung cancer. Well, this lung cancer is famous for causing paraneoplastic manifestations. Oat cell cancer has been discussed to contribute to SIADH, which will cause delusional hyponatremia. It can also contribute to ectopic ACTH production, resulting in Cushing syndrome manifestations. Micromets are anyway there. Even it can contribute to neurological manifestations, which is called as Lambert-Eaton syndrome. So, oat cell cancer has come up for the fourth time after discussing the standard ones like SIADH and the ones that I've highlighted. Even HLSA cardia has been documented. In fact, they have highlighted that in this condition, there are some antibodies produced by this nasty lung cancer called as anti-Hu antibodies. And these antibodies then go and damage the Auerbach plexus and they affect the motility of the esophagus, contributing to this disorder. Now, what actually is the main problem in this guy? I mean, you can definitely see on the monitor at the moment the bird beak appearance of a barium swallow, but I want to again highlight that the investigational choice for this condition is not a barium swallow. The investigational choice for this condition is again esophageal manometry. Now, we have studied why is it occurring. Now we will talk about the pathogenesis component of the disease, that what actually happens. Why do you have HLSA cardia? Why do you have this constriction? The first answer of yours in this motility disorder will be that this condition causes aperistalsis, that is the lower one-third of the esophagus specifically does not exhibit routine peristaltic waves. The second problem in this patient is more surprising, in fact, that there is an increase in the lower esophageal sphincter tone, and the usual query that I get from my students is how is that possible? It's causing local damage, so it's gonna cause a decrease in tone. Well, you are aware that for motility of the esophagus, we have Auerbach plexus, we have a Main-Trach plexus. In this particular case, what happens is that the inhibitory control is lost. So this contributes to increase in the tone of the sphincter. The sphincter will become more difficult to open, which means the fact that when this person will eat food, the food will keep on accumulating in the esophagus. It won't go down into the stomach because the sphincter is tightly closed. Now this person will drink a full glass of water. Now the weight of the water in the food due to gravity will be more than the tone of the sphincter, and the food will then trickle down into the stomach of the patient, and once the weight reduces, well, the sphincter closes again, and therefore there would be some food and some water always left behind. I want to highlight that in you and me, whether you're drinking water, you taking semi-solid food, whether you're taking solid food, everything goes from the esophagus directly into the stomach. Not a single drop of water remains behind. In this condition, the food will not go down because the sphincter is very tightly closed. So let's look at the clinical features that will evolve in this condition. Most of the time, autoimmune disorders are more common in young females. He will describe progressive dysphagia. The autoimmunity part keeps on worsening the disease presentation of this person. If I was talking about progressive dysphagia in a geriatric age population, first to be thought of is cancer always. Now, as I said, food is not gonna go down. It would remain behind in the esophagus, so there could be rotting of food and water contributing to halitosis. There would be regurgitation of yesterday's food items. I have highlighted this for the second time today that regurgitation of yesterday food items is a feature that you see both with Zenker diverticulum as well as with achalasia cardia. But the difference is very well obvious on the slide before you. This time you're not gonna think in terms of Zenker because we are talking about progressive dysphagia developing in a person. Lots of time he might even help you by writing dysphagia more for liquids as compared to solids. Now, why is that so is a common query from lot of students. So I would like to explain that you see liquids are lighter. So the weight of the liquid may not be sufficient to open the sphincter. So he might have to drink lots and lots of water and then it will cause the weight of the water to be substantial that the sphincter relaxes and the food goes down or the water goes down. But if you compare liquid versus solid, solid is heavier. So still the weight of solid will be more. It will be able to open the sphincter and the food will go down relatively better. So on a comparison basis, though I would like to highlight all patients are not so intelligent enough to say this statement that I have more problems with liquids as compared to solids. But this is a useful MCQ tip which is present. And even if it is not given, you should still be able to identify the question based on the gender part, on the young age group of the patient, and because progressive dysphagia is given, so Zenker's diverticulum is off the radar. Since the food remains in the esophagus, there could even be aspiration episodes developing. I'm not talking about a huge big aspiration like Mendelssohn syndrome. I'm talking about micro aspiration that can occur when these people are sleeping. So therefore you will read about recurrent pneumonia episodes developing in these patients. This is definitely bad news because this can contribute to the mortality component in these patients also, because if it's recurrent pneumonia episodes, even bronchiectasis and serious lung disease manifestations can occur. The investigation choice for this condition should be answered as esophageal manometry, where the tone of the sphincter will be found to be more than 25 millimeter of mercury. We all have a bias towards answering barium swallow because we see a lot of images of barium swallow in the textbooks, and even surgeons love to show a lot of such images which are very classical ones from standard textbooks. So this bias can come. When it comes to a barium swallow finding of this patient, the main finding that you will encounter will be a bird beak defect, which can be confused with a rat tail also. I'll try to explain to you how both can be differentiated. Do remember the fact that bird beak versus pencil tip, they both imply the same. In a few seconds from now, I'll explain to you how to differentiate from a rat tail appearance. Please remember the fact that the treatment of choice for achalasia cardia would be answered as Heller's myotomy. And because this myotomy procedure is done, there could definitely be a reflux developing in the form of GERD in the patient. So to prevent that from happening, we will also have to go in for a second procedure, that is partial fundoplication. So this is taught in surgery also. The treatment of choice is Heller's myotomy with partial fundoplication. However, if a person is not willing for surgery or is a high risk patient for surgery, in a sense that this lady is having some concomitant comorbidities, the person has refused or the anesthesiologist has refused surgery, in those circumstances, botulinum toxin injection can be given in the lower part of the esophagus. That will again help in relaxation of the tight sphincter, as well as the aperistaltic segment will tend to relax a bit because the inhibitory control now is lost. Apart from botulinum toxin, drug support can also be used. If the person has refused everything that I've written on the board, then even calcium channel blockers can be used, but don't answer nitrates. Nitrates were mainly answered for diffuse esophageal spasm. Here I want to highlight two diagrams simultaneously. In one of them, you can definitely notice a very classical bird beak or a pencil tip appearance. But in the second one, you will notice that there is an irregular filling defect that is present. So the key word is, you see the word rat tail versus pencil tip is disputed because both are having, English nomenclature being used. For we as doctors, we need to mainly remember the word irregular filling defect versus the regular filling defect. In fact, sometimes in MCQs, he might even use the word shouldering sign. So when it comes to a cancer, it is always to be thought of a malignancy. Though obviously the best way for diagnosis of malignancy is endoscopy with a biopsy. You get a tissue diagnosis also. But shouldering sign, irregular filling defect, both of them, they point towards etiology of carcinoma esophagus. The commonest one is squamous cell cancer. In lower one third is obviously esophageal cancer is adenocarcinoma, but overall is squamous cell cancer. On the right hand side, it's a regular filling defect of achalasia cardia. Now look at the twist in the question that can come. So please be very attentive in the next 2 minutes. The question began in the exam by describing a 25-year-old female. He also described that this lady is having progressive dysphagia. The standard features that I've told even for achalasia cardia were given in the question. However, subsequently, he modulated the question by saying that esophageal manometry when performed revealed that the tone of the sphincter is reduced. Now that is the surprising part that I'm saying, that in achalasia cardia the tone of the sphincter was more. Here he said reduced. You need to pick up this question and answer the diagnosis as scleroderma. You see, if you focus on the word scleroderma, well, there is sclerosis or fibrosis in the skin. It can involve even the sphincter. Though in the MCQ, he also mentioned a lot of other subtle hints. Like for diagnosis of scleroderma, he will always talk about leather-like skin appreciated in a person. Or he can talk about early manifestations like Raynaud's phenomenon. He can definitely make this question relatively long by showing a multi-system involvement which will cause you to waste your time. He can also talk about scleroderma crisis because the kidneys will shrink in size, so person can go into hypertensive crisis. He will not write the word scleroderma crisis, then you know the diagnosis. He will try to explain a person having high blood pressure with Raynaud's phenomenon, with leather-like skin, with progressive dysphagia, with a decrease in the tone, and in the maze of so much information provided, we tend to lose focus on the keywords that I've highlighted with a different ink here. The tone of the sphincter is lesser. In these circumstances, the current diagnosis of this person is scleroderma, and now for diagnosis of scleroderma per se, I will not be doing a manometry. Manometry report is already given to me in the question. Tone of the sphincter less means manometry report is given, no? So you will not answer manometry in this question, which couple of people casually answered because tone of the sphincter was given. They said manometry. The point is, for diagnosis of scleroderma, you need to run an antibody scan. That is gonna be anti-topoisomerase antibody. I have discussed scleroderma in rheumatology section also, but I want to highlight this statement of mine. When you read a question of a geriatric age group person with non-progressive dysphagia, you have to think in terms of Zenker. If it is old man with progressive dysphagia, you need to think in terms of a cancer. If you talk about a young female, two differentials. It could be scleroderma, it could be achalasia cardia. What is the differentiating feature? The differentiating feature is the tone of the lower esophageal sphincter. It's gonna be upregulated or increased in achalasia cardia. It's gonna be down in the dumps in scleroderma because there's definitely significant fibrosis occurring in the wall of the esophagus. That's why you read about esophageal dysmotility even in the literature of scleroderma as well. I would like to now summarize the topic of dysphagia. I would like to subdivide the discussion into two parts. One can be oropharyngeal causes and second can be esophageal disorders which can explain the symptom. For the oropharyngeal component, one can be structural defects. One of the common structural aspects that I have highlighted is Zenker diverticulum, which was having non-progressive dysphagia. But you also need to keep in your mind regarding neoplasm, which will be having a progressive manifestation. Apart from this, another structural cause which I am mentioning right now is a upper esophageal web. In fact, you guessed it right, I'm talking about Plummer-Vinson syndrome. In majority of MCQs of Plummer-Vinson syndrome, the term upper esophageal web may not be written and he will write the word post-cricoid dysphagia. Along with this, iron deficiency anemia and chylionicea would be describing the triad. I can also raise a controversy here, which is that in some books, the triad of Plummer-Vinson syndrome rather incorporates the term glossitis, whereas I have not spoken about it. I want to highlight that in major gastroenterology books and even in Harrison is mainly mentioned about these three. The glossitis component is not mentioned in Harrison. So I would like to take that as a reference for Plummer-Vinson, formerly called as Patterson-Kelly syndrome. Now, not only structural, there can be neurogenic causes also. Neurogenic causes of oropharyngeal dysphagia, where the person will say that the food sticks in the throat, not in the chest, but in the throat, could be due to cerebrovascular accident. And I can then talk about a disease of the neuromuscular junction. I'm writing the word myopathic because muscles are not working properly, but it's actually a disease of neuromuscular junction, that is myasthenia gravis. And even in Lambert-Eaton syndrome, in some cases, dysphagia can be described. So we definitely need to avoid that bias that only the specific esophageal disorders that we have discussed are the ones which are responsible. In fact, oropharyngeal always have to be ruled out first before we start thinking in terms of what we have discussed as standard esophageal disorders contributing to development of dysphagia. Here I also want to highlight a condition where a person is told not to eat non-veg. You will tell this guy, sir, veg you can eat, even if you want to eat chicken or meat or non-vegetarian items, they should be minced properly. Can you think of a medical condition related to esophagus lower one-third where you have specifically told your patient not to eat non-vegetarian food? I'm very sure all of you in surgery have read regarding Schatzki's ring. Please remember, upper esophageal web I was speaking about, that's upper esophagus, but Schatzki's ring is found in the lower one-third of the esophagus. The highlight of this condition is meat impaction. Do remember the fact that Schatzki's ring is not a pre-malignant condition, it's just a malformation that will contribute to dysphagia in the patient. In fact, due to meat impaction, these people can even develop aphasia and then a possible esophageal perforation as well. That's an important cause which is to be remembered from the exam perspective. Though there are many others that I've highlighted before you, but these are additional aspects that I have tried to highlight. I've talked about the triad of Plummer-Vinson, I've talked about meat impaction, which are two important issues. You see, actually there's a table in Harrison where all these causes are explained, but instead of trying to, just mark it on the table like tick mark, these are the causes, I've tried to highlight the important ones. Like if I just zoom into the table, you can see one of the structural issues that he has always talked about is Zenker diverticulum and a neoplasm. And when it comes to a neurogenic cause, one of the important cause to be considered is cerebrovascular accident, though even Parkinsonism and amyotrophic lateral sclerosis can be having issues with feeding, and the topics are definitely covered in neurology. So I want to highlight the fact that do not be under impression that all questions that will come to you will be of esophageal dysphagia, because when you read the word dysphagia, the impression is about the diseases that we have studied. I want you to have a broader whole perspective. Like for example, if a question begins by a young female, and he says that this lady is having difficulty in eating his breakfast, or let me say this lady is able to finish her meal over a long duration. She eats very slowly, and if she tries to gulp milk fast, she literally chokes on it. The disease that you're thinking here is a disease related to the voluntary aspect of swallowing. You see, the tongue has become slow. Person is not able to gulp milk, or it takes her long to finish the food. She is first one on the dining table, last to get off it. I'm talking about myasthenia gravis. In myasthenia gravis, because myasthenia gravis is not a disease of the smooth muscles. Myasthenia gravis is a disease of the skeletal muscles. So it is the voluntary component of swallowing that will be affected there. But still the question will specify the word oropharyngeal dysphagia, where the person will specifically mention that when I try to drink milk fast, I feel as if it is stuck in my throat or as if I'm choking on milk. So when you read about dysphagia as a symptom, think in the exam, is he talking about a oropharyngeal aspect or is he talking about the standard esophageal disorders, which are, I think, relatively easy. I mean, you guys are smart chaps, so esophageal disorders you will not have a problem with, but even the myopathic component or the neurogenic component that I've highlighted should also be kept in mind. I will now discuss two cases with you before I discuss Barrett's esophagus subsequently and gastroesophageal reflux disease. I want to highlight the fact that lot of questions that are coming nowadays can be actually a overlap between medicine and surgery. So that is why I have to discuss two more topics here, but in the form of questions. I'm describing this 30-year-old guy. He is alcoholic, like he works in a call center, good salary. So, well, if somebody starts earning money, people tend to spend it on booze. So this guy has gone to a club with his friends and they've ordered, multiple pints of beer and he is doing binge drinking. And following that, he starts having vomiting also. So his friend, or maybe he went with his girlfriend and he and his girlfriend are drinking themselves silly. So maybe a friend or anybody is accompanying him into the washroom and he's having retching now. Like he has vomited so much that whatever he had eaten, snacks, non-veg, etc., everything is out. Now the stomach is empty, but the retching sound is being produced and he pukes and then he starts experiencing severe chest pain and crashes on the bathroom floor. Syncope. So his girlfriend is panicky or his friend is panicky and they are brought to the hospital by the restaurant staff. They escort them to the hospital or in ambulance is brought to the hospital, where when you're doing a physical examination of this patient, you are noticing that he's having puffiness of his eyes. This puffiness of the eyes is because he's having subcutaneous emphysema, or he might say crepitus below the skin. You see, when I say this statement, you are very comfortable with the fact that I'm not discussing malarivius, because in malarivius there was no subcutaneous emphysema. The question will waste your time with the vitals also. It would be like a heart rate of 120 per minute. It could be a blood pressure value which is on the lower side, let me say only 90 by 60 millimeter of mercury. Why? Because this guy is having pneumomediastinum, and because of this pneumomediastinum component, the air would press on the great veins like SVC, IVC, so the venous return on the heart can definitely be compromised. Well, at this point of time, I want to highlight regarding the following aspects. This guy is puking, vomiting, there is chest pain in this guy, there is a subcutaneous emphysema. So I'm talking about macular striae in this condition, which will help you in making the final diagnosis. In fact, sometimes it could be a two-step question. He knows the fact that you are definitely smart enough to answer Boyrave syndrome right away. The moment you read these features, he will ask you how would you work it up. I want to highlight the fact that Boyer's esophagus would be a tear. It would be a through and through rupture of the esophagus, causing spilling of the contents of the esophagus into the mediastinum. Why was he having a chest pain? The reason for chest pain in this guy, the reason for chest pain in this patient is chemical mediastinitis. You see, esophagus does not have nerves, no, that it will through and through rupture and person will have chest pain. It is chemical mediastinitis, it is saliva, it is the food, the alcohol that has now come into the mediastinal cavity of this patient when the esophagus through and through ruptured, and mostly this occurs in the lower one third of the esophagus posteriorly because esophagus is weakest posteriorly. The chest pain of this chap is explained by chemical mediastinitis. It is usually the lower one third of the esophagus that will be affected. Why I repeated that lower esophagus thing is because I want to tell you that suppose a person is undergoing a upper GI endoscopy, that is instrumentation of the esophagus is occurring. You are familiar with the fact that whenever you read a question regarding instrumentation of the esophagus and a rupture of the esophagus or a tear of the esophagus, it is the cervical esophagus, the upper part, that would be affected. So do take care of this fact that you read about Bohrav syndrome with instrumentation and also with respect to what I've described. Well, alcoholics having recurrent vomiting, you see, it could be malarious, it could be macular striatal or Bohrav syndrome, so you need to keep a watch up for that. Now I come to the main agenda, why I'm talking about it. He will rather not ask you the diagnosis, but will say, what is the main test for diagnosis of this condition? You see, if you will be doing an X-ray chest in this guy, you will definitely be able to get a continuous diaphragm sign. That's a standard radiological finding of pneumomediastinum. But the point is you need to demonstrate the tear, you need to demonstrate the chemical mediastinitis component. So you will be doing a CT chest of this guy, and next what I say will sound controversial to you, but it is not controversial because this is what Harrison says, CT chest with oral contrast. When I say this, a lot of guys will say, sir, barium, you are giving him orally, there's a tear, it will go in the mediastinal cavity, won't that cause worsening of chemical mediastinitis? So I'm gonna be smart, I'm not gonna use barium in this case, I'm rather gonna use a gastrocaffeine contrast. I want to highlight the fact that for these particular patients, it is not plain CT. It is CT with a water-soluble gastrographin contrast which can be given because you need to demonstrate the spillage of the contents into the mediastinum to demonstrate a through and through perforation. You see, please appreciate, tear can be partial thickness, tear can be full thickness. Suppose serosa is intact. If serosa is intact in this guy, then in those circumstances, there would be no chemical mediastinitis occurring. But if there is a tear of the serosa, then chemical mediastinitis will definitely occur. So I need to demonstrate that the serosa is gone. And now the contents are spilled over into the mediastinal cavity. So a CT with oral contrast followed by obviously a surgical repair of this patient will be done, and concomitant even a pneumomediastinum can be present in this patient. Continuous diaphragm sign per se will be air above the level of the diaphragm. You see, gas will the diaphragm is a feature that you see with perforation peritonitis, but in this case, the gas will be seen around the heart of this person. On an X-ray, I can highlight like this. If these are the lungs, this is the heart, right? So you would be able to see, I'm showing air in black, air just below the heart. That's why we call it continuous diaphragm, no? Because the diaphragm looks contiguous. So most of the time, the air shadow is seen in and around the heart. And why I'm highlighting that is because you see this air is atmospheric air, no? So it will put pressure on the great veins. Therefore, the filling of blood in the right side of the heart is compromised. The venous return definitely takes a hit in this case. The slide that I've discussed here is Bohrav syndrome, has an overlap with surgery. So I would request you to kindly go through that also. And let's do one more case here so that we are more comfortable with the discussion. I'm today describing a case of a 30-year-old lady who came to my clinic because she was having excruciating epigastric pain. So on listening to epigastric pain, I prescribed her a PPI, But the pain was so bad that she was like squeezing her epigastric area with her hands and she was literally in tears. So I thought, okay, I told my nurse, give her IV pantoprazole. I thought after half an hour to 1 hour, pantoprazole will take its effect. This lady will feel fine. But unfortunately, in spite of giving this intervention, the pain is not going away. This lady is also complaining that she is feeling pukish, but there is no vomiting. If I vomit, I'll feel better. These are the words of the patient. She says, if I will vomit, I think something is stuck up here, something is knotted inside me. I feel if I will puke, I will feel better. She's having nausea, but there is no vomiting present at the moment. She says that if vomiting will occur, I will feel better. So because of the discomfort of this lady, I thought maybe she's having a big ulcer and she's bleeding inside. Let me do a NG tube aspiration, just do a stomach wash of this person so that I am more sure about my diagnosis. I have decided to put a NG tube in this patient. She's cooperative. You see, normally when you put in an NG tube, because it causes a gag, the person might hold your hand, pull out the tube, stuff like that. She has been gracefully cooperative, but you are not being able to pass the NG tube. You have put so many nasogastric tubes in your career that you're wondering what's going on, man. I mean, you measure the endotracheal tube for the appropriate size, but it's not going inside, as if it's stuck somewhere. Well, I'm not discussing a stricture of the esophagus, guys, because stricture is something that you see with the some kind of a corrosive acid ingestion in the past. Like in this lady, there's no history of any suicidal attempts in the past. Her mental health is good, so she's never attempted anything wrong with respect to harming herself. She's just come to you today, working professional, successful in a career, maybe a mother of one child, happily married, and today she's having so much of epigastric pain and you are not able to pass a NG tube. Well, what is your diagnosis? The hint is that the triad that I have described here before you is called as Borchards triad. In Borchards triad, there will be three things. There will be epigastric pain, there's nausea minus vomiting, and failure to pass NG tube. Yes, guys, the clinical diagnosis of this lady would be given as stomach volvulus. Again, a topic that will be having a surgical overlap, but I want you to be aware of the fact that lots of time patients, when they come to you, they'll put their hand like this. This might be retrosternal pain / epigastric pain. That would be the description in the question. But then the key word in this description is this one: failure to pass NG tube. You don't read this anywhere else in medical literature. Failure to pass NG tube is what you always read only with the stomach volvulus. You are aware of the fact that the stomach volvulus can either be occurring like this from bottom upwards. Inferiorly is the mesentery. So he will use the word mesenterico-axial volvulus, or it might occur like this from the lateral to the medial side. That would be referred to as organoaxial volvulus. So whenever you read regarding the two types of the volvulus, the examiner will definitely try to incorporate which is relatively more common. So I think you know from surgery that organoaxial volvulus is relatively more common than mesenterico-axial volvulus. What will you do in this case? For diagnosis, the investigation of choice, management will obviously be surgery. You'll have to open up the patient, get the stomach back into a normal situation. Otherwise, this chap has had it. I mean, there's a distinct possibility that in this individual, there might be even gangrene in the stomach because the stomach is folded on its own axis. The investigation of choice for this condition can either be a barium study, but to make a person so sick, drink barium and then take an X-ray will be a little more difficult. So most of the time we'll be more comfortable diagnosing this condition with the CT abdomen. Yes, we will try to make the person take oral contrast. You see, if the person has lost consciousness, you can't give oral contrast. You just do a plain CT abdomen. But in this case, at least the person has borne all this pain, because sometimes the pain can be so bad that person can develop vasovagal syncope. Person may not be properly responding to your commands. So making a person sick enough, not being able to respond to your commands, drink something is a little dicey. In this particular case, though, ideally I should go for CT abdomen with oral contrast. The contrast will not go forwards. In some books, it is written that barium contrast studies can be done in these patients. They just use this word. Now, I think you would agree to the fact that lots of time in radiology units, barium contrast studies may not be available. A person skilled enough to interpret that may not be available at the later part of the day. So, CT abdomen with oral contrast is a reasonable way, following which you can definitely handle this patient. As I have highlighted before you, failure to pass angiotube is a very classical terminology that you need to remember for Bouchard's triad. They've also asked that when you're putting an angiotube in a person, the patient should be sitting or supine. You see, if a person is unconscious, comatose, you can put angiotube in supine position also, but in a routine conscious person, you should always try to put the angiotube in a sitting position with neck partially flexed. The reason why the neck is partially flexed is primarily to prevent any chances of the tube accidentally going into the airway, or if God forbid he pukes, then the chances of the vomiters going into the airway will be relatively minimized. In fact, when you're putting in the NG tube, the moment it goes into the throat, the gag reflex comes in. So you can give a glass of water to the patient with a straw. And the moment he will feel the gag, you have to tell him, don't hold my hand when I'm pushing in the tube. Don't try to pull the tube out. If you feel as if you are having a gag, all you need to do is you will have to drink water from the straw. So when he will drink water from the straw, two things will happen. One, water will help in lubrication, so the tube will be facilitated in going down. Plus, the peristaltic waves themselves will help in carrying the tube down. So most of the time when you are putting an NG tube in your patient, the patient should be setting up, glass of water in his hand with a straw. When he feels the gag, ask him to just sip water and the tube goes into the stomach. Once the tube is right at its original position in the stomach, you will obviously use a 20 ml syringe, 50 ml syringe, and you need to push air and auscultate over the epigastrium to be sure that the tube is at the right place. All of you have put NG tube so many times in your patients that there will absolutely be no problems. But the only scenarios where the tube is not gonna go is either gonna be a nasty stricture, which is unlikely to come, because as such, you see, if person is already having a stricture, that person will seek medical intervention. We'll do an endoscopy, we'll deploy balloon dilatation, would have been tried in the person. So past medical history will always be given if he wants an answer as a stricture. But in this case, I described a working professional, a young female, absolutely no problems with her health previously. And now she's had this situation that she's rolling in the bed with epigastric pain, and I'm wondering, am I having a peptic ulcer perforation? But there's no guarding, there's no rigidity. So this could be a question which could be 3-liner, 4-liner, depending on if he starts incorporating features which will be ruling out peritonitis. It will obviously become a long question. Currently, the pattern is like this. They are overlapping and integrating the subjects, so that is why these aspects I have highlighted, though you have read them in surgery as well. The next topic that I'll explain to you is gastroesophageal reflux disease. The tone of the sphincter will be substantially reduced in this patient. Why it is reduced could be due to obesity, it could be concomitant alcohol intake, nicotine intake, cigarette smoking. The primary complaints of these patients would be a retrosternal pain. The patient will always put his hand or finger to the chest. You see, if a person is having diffuse chest pain, he will always put his whole of the hand to the chest or maybe a fist to the chest like this to describe the coronary etiology of pain. I mean, person does not know coronary etiology, but if a person is putting his hand like this on his chest, I am thinking that it could be a diffuse chest pain related to cardiac origin. But if he points with his finger like this, that would mainly be gastroesophageal reflux disease. In a large number of these patients, you will read about sour brush, like these patients are sitting on a chair comfortably and suddenly a sour fluid comes in the mouth. Now, acid and teeth, which are having calcium, do not gel together. So these patients might be having requirement of multiple dental procedures. Dental enamel of these patients can be eroded, mainly in the molar teeth, primarily because of the acid causing damage to the dentine enamel of the tooth. These patients will cough a lot when they're sleeping. They're not gonna be aware of it, or they may not be distressed by it, but their family members will always say that, why do you cough so much at night? Well, when this person is sleeping, there's a possibility that there might be aspiration of acid. I'm not discussing Mendelssohn syndrome. All I'm saying is maybe few drops of acid, few microliters of acid went up from the esophagus into the trachea when this person was sleeping. So chemical tracheitis will contribute to nocturnal cough in these patients. In fact, there's a distinct possibility that the MCQ of GERD will deliberately begin by describing nocturnal cough, and you need to be knowing that nocturnal cough is also read by you in asthma. If a person is having infection of the adenoids, then this person can be having post-nasal drip, and that can also explain the nocturnal cough. I have today taught you 3 reasons for why nocturnal cough could be present. It could be asthma, it could be post-nasal drip due to infected adenoids, or gastroesophageal reflux disease. A lot of these patients might be coming to your clinic for recurrent courses of antibiotics, because initially when they came to you, all they told was that I'm having a sore throat. So you thought it is some infection, a bacterial infection. You prescribed antibiotics like Augmentin or azithromycin, whatever. But you now are realizing that this person was actually having tendency for recurrent sore throats, not because the person was having any infection. It was the chemical laryngitis component responsible for it. Due to GERD, the patient will also be distressed, and with anxiety, the symptoms will worsen. The investigation choice for this condition is 24-hour pH monitoring. You are aware of this, no big deal. The question in the exam said, esophageal pH should be less than how much to call it gastroesophageal reflux disease. Then remember a value of pH less than 4. For a duration at least more than 4 hours on a daily basis. I repeat the statement. If you document by 24-hour pH monitoring that the pH is less than 4 for more than 4 hours per day, it is diagnostic of gastroesophageal reflux disease. The main treatment for this person will be proton pump inhibitors, and you can obviously have improvement in the condition by adding prokinetic agents. In 24-hour pH monitoring, you would be putting in a probe. This probe will be having sensors. The sensors will be recording the pH of the esophagus and the pH of the stomach. In the exam, he was so specific that he even went to the level of asking that this sensor will be present how many centimeter away from the lower esophageal sphincter. I want you to remember that the sensor of the esophagus and the sensor in the stomach both are present 5 centimeter away from the lower esophageal sphincter. You can see the LES have shown in blue color and the sensors in color red. So just remember this value here, which was again a technical aspect that was asked, and usually we do not expect such detailed technical aspects to be asked in the exam. For the treatment of this condition, as I've said, plain PPI can definitely be used, but you will notice that if you combine pantoprazole with domperidone or with prokinetic agents, then the relief of the person is relatively better. Because see, the problem in this chap is lots of time not more acid. It is actually acid going up. So if you give a prokinetic agent, then the incidence of severity of illness will resolve even faster. The main drug of choice is PPI, no issues with this. I just said that if you will add etopride, cisapride has been banned from the market. I presume you're aware of it because cisapride causes torsades de pointes that I've discussed in cardiology. So nowadays we do not have cisapride, we have etopride, we have musapride available, or the traditional domperidone can be used as a 30 milligram sustained release capsule that will help in improvement of this patient. If GRD symptoms are persistent in a patient, then we also need to keep in mind a possibility of hiatus hernia. The topic of hiatus hernia has to be read by you from surgical domain because there are two of them, rolling hernia and sliding hernia. So please read that from the surgical domain. I just want to add the fact that the question in the exam said Cameron ulcer. Because traditionally we have studied peptic ulcer, you will study regarding curling ulcer or burns, Cushing ulcer or raised ICT. The question said Cameron ulcer is found in, remember the statement of mine, Cameron ulcer is found in hiatus hernia. Curling ulcer is seen with burns in the duodenum, but Cushing ulcer is found in the stomach. I repeat the statement again, I'm not writing it because you are aware of it, but you tend to neglect it. Cushing ulcer of raised ICP is more common in the stomach, and the curling ulcer of burns is more common in the duodenum. Now, if a person is having gastroesophageal reflux disease, then the bad news is that he can develop a Barrett's esophagus. Slide of Barrett's esophagus from pathology is always asked. What are you going to look at? You are going to look at presence of goblet cells in a slide of esophagus. I mean, goblet cells are in the small intestine, no goblet cells in the esophagus, because the epithelium of the esophagus would be a traditional columnar epithelium. Here you are having interspersed with goblet cells, which is definitely not normal. The investigational choice for Barrett's esophagus is upper GI endoscopy with biopsy. Though the color of the mucosa in Barrett's esophagus is also different, I want you to understand per se the fact that when it comes to Barrett's, the best way for diagnosis is a combination of endoscopy with a biopsy. It would be a punch biopsy, and then you will go for surgical resection of the afflicted part. He will also ask you here that if you are gonna resect some part of the esophagus, then what are you gonna do for that component? So please appreciate the fact that if you remove some part of the esophagus, we are not gonna put colon there, which was done when I was student. We used to read about colon transposition. Now we go in for stomach mobilization. The surgical details you will obviously be familiar with and will read in surgery also, but I just want to highlight the fact that this condition is having a metaplasia followed by dysplasia. Please remember the fact that if the question says what is the most common type of metaplasia, please appreciate that I'm talking generally. I'm not speaking about what is the change that is occurring in Barrett's esophagus. That I know you are aware of, squamous to columnar. In the exam he said, what is the most common type of metaplasia? Then the answer is not gonna be given as, please appreciate my statement. Overall in the body, the most common type of metaplasia that you encounter is columnar to squamous. The concept is that in our lungs, we are having a ciliated columnar epithelium, and that ciliated columnar epithelium will now get transited into a squamous, that would be a squamous cell cancer in genesis. So do remember